time to look at a few questions on the topic of glaucoma which have appeared in the past year exams. Some high-yield topics on glaucoma include anti-glaucoma medications, questions pertaining to optic disc changes or visual field changes in glaucoma, secondary glaucomas with special emphasis on lens-induced, pigmentary and pseudoexfoliation glaucoma, and I've touched upon pigmentary and pseudoexfoliation glaucoma in the cataract part of it, where we were dealing with pseudoexfoliative changes on the anterior lens surface. And I talked about Kuchenberg spindle and other pigmentary changes in the part where I talked about corneal disorders as well. So we'll sneak peek into this wide field of glaucoma, and this is something that I'm very passionate about. So I'll take every opportunity to explain things in a very simple manner to you. So let's have a look at our first question. We have a newborn child with big blue eyes and watering, blepharospasm and photophobia. What could be the probable diagnosis for this child? Could this child have congenital glaucoma, mucopolysaccharidosis, cataract or ophthalmia neonatorum? So look at these large corneas. Even we as adults don't have such large corneas. There is so much of fluid imbibition into this cornea that it has become hazy and it has become cloudy. So corneal clouding, the large size, this in previous days was called as Buphthalmos or hydrophthalmos. Now that's not the terminology that we use these days. This child also has watering because of irritation of the sensory nerve endings, and once the mother tries to expose this child to bright light or even sunlight, the child shies away and watering increases even further. Now there are several variants to this. The disease that this picture is pointing towards is congenital glaucoma, and there are several variants to congenital glaucoma. Newborn onset, seen in children less than a month. Infantile onset, when the child presents with such symptoms after a month of birth up until 2 years. Late onset or late recognized, which is usually seen beyond 2 years, or spontaneously arrested cases where there was a triggering element. The child had high pressure in the eye that led to stretching of the sclera and enlargement of the cornea, but due to certain changes in the eye or the body itself, that got arrested. Now this is quite rare, but classic findings of Haab striae and stretched out cornea with normal intraocular pressure may be noted. So for us, one of the easiest things that helps us to clinch this diagnosis is measuring the size of the cornea. So corneal diameter is measured horizontally, white to white. In newborn, the normal is about 9.5 to 10.5. Anything more than 11.5 is suggestive of glaucoma. For a child of 1 year of age, about 10 to 11.5 is considered normal, and anything more than 12 is abnormal. Child of 2 years, anything more than 12.5, and a child beyond 2 years, anything more than 13 is considered abnormal and suggestive of glaucoma. So these numbers you must remember corresponding to the age of child to help you clinch the diagnosis. Now, there are several disease entities which can have similar presentation. So, the differential diagnosis for congenital glaucoma can be done when we consider different presenting symptoms. So, if the child is presenting to you with watering in red eye, the child could have conjunctivitis, but of course, there would be no enlargement of the cornea in such a patient. Or there could be nasolacrimal duct obstruction and the child could have constant watering. Because of the watering, the child could be irritable. But if you look at the cornea again, there would be no corneal signs. There can be a corneal epithelial defect if the child has keratitis or anterior segment inflammation. And because of this epithelial defect, the child would have blepharospasm and watering. But if you look at the eye, the size of the cornea would be okay, and that would, point it not being congenital glaucoma. There can be other conditions which can produce corneal clouding, and that would be because of birth-induced trauma, if forceps are used at the time of delivery. There could be a congenital malformation, corneal dystrophies, keratitis, mucopolysaccharidosis, or any other idiopathic pathology that can lead to corneal opacification. Now, I've used the word Haab striae, and when I was talking about keratoconus in the cornea part of it, we talked about Vogt striae. So, I had mentioned H for horizontal, Haab striae, and V for vertical, Vogt striae. So, let's just quickly revisit the difference between these two types of striae. Haab striae, which are horizontal striae, as you can see here, are very characteristic of congenital glaucoma. They are curvilinear plaques in the descemet membrane. Vertical folds are seen in the descemet membrane, and they are Vogt striae, as you can see in this image. That's very characteristic of keratoconus. Vogt striae occur in nearly 65% of patients with keratoconus, while Haab striae occur in about 25 to 60% patients of congenital glaucoma. Vogt striae are nothing but stress lines in the descemet membrane, while Haab striae are actual tears in the descemet membrane, so they do not disappear when you apply pressure of the eyeball. Haab striae can affect vision by causing astigmatism when they cross the visual axis. Had been in this region, they would have resulted in drop in vision of this child. So, glaucoma, if it is diagnosed only after a cataract surgery without any pre-existing glaucoma, then it is called as glaucoma following cataract surgery. It could be following a congenital idiopathic cataract or a congenital cataract which has been associated with other systemic diseases. If that's not the case, we could be dealing with congenital eye anomalies or systemic syndromes. Now, if the child has any other systemic feature, the child would have glaucoma associated with non-acquired systemic disease. Now, this new classification that I'm talking about is called as CGRN classification, the Childhood Glaucoma Research Group, which gives this modern classification which covers all aspects of glaucoma, whether it is post-surgical, whether it is associated with a systemic disease. If there is no systemic involvement, but there is history of trauma or uveitis or steroid use, or the child has retinopathy of prematurity or some tumor, we are dealing with glaucoma associated with acquired disorders. So, a tumor or an ROP or uveitis is something that the child is acquired. So, they can have either a glaucoma in an open angle form or an angle closure form. If this is also not the case, then the child has Buphthalmos. So, there is no cataract surgery, there is no non-acquired systemic disease, there is no acquired condition which is contributing towards the presentation of the child. Only then do we label as child having Buphthalmos, and since that's not the term that we use now, we will be using two terms, that is the primary congenital glaucoma or juvenile open angle glaucoma. So, it's primary congenital glaucoma of neonatal onset, of infantile onset or late onset, and anything beyond 2 to 35 years is juvenile open angle glaucoma. So, a quick recap of CGRN classification that is used these days: glaucoma following cataract surgery, glaucoma associated with non-acquired systemic diseases, glaucoma associated with acquired conditions, or primary congenital glaucoma if we are talking of age up until 2, and beyond 2 up until 35, juvenile open angle glaucoma, and beyond that we have the primary open angle glaucoma. So, the child also had blue sclera. Not all blue sclera are associated with glaucoma. There are certain other disease entities in which the child can have blue sclera. And these entities include osteogenesis imperfecta, Marfan syndrome, Ehlers-Danlos syndrome, pseudoxanthoma elasticum, high myopia, or heel scleritis. Now, look for other parameters in the eye before labeling the child with glaucoma if you just look at blue sclera. So the condition of the cornea, the intraocular pressures, the optic nerve head all need to be put in the picture before labeling the child as having congenital glaucoma. So in our case scenario, lacrimation, photophobia and blepharospasm have been talked about, and this is the classical triad for primary congenital glaucoma. Lacrimation is the most common symptom that is seen, followed by photophobia. Such a child will rub their eyes a lot, and rubbing the eyes actually worsens it. This rubbing is because the child has irritation of corneal nerves, which occurs because of the elevated intraocular pressure. A very good thing about congenital glaucoma is once you control the intraocular pressure, then the cupping, the optic nerve head cupping in such a child is reversible and the child gets a good prognosis. The only thing is to clinch the diagnosis in time and treat it timely. Going on to the next question, in the glaucoma subset, following feature is not a feature of optic disc in glaucoma. Roenne's nasal step, the bayoneting sign, increase in cup disc ratio or bearing of the nasal arteries. So here we have a normal optic disc. This is the cup. This is the neuroretinal rim. That's quite healthy. And we have a rule which is called as the ISNT rule. I is more than S is more than N is more than T, where I is the inferior rim, which is more thick as compared to the superior rim, which is more thick as compared to the nasal rim, which is more thick as compared to the temporal rim. Now, in early glaucoma, it is usually the poles that get involved. So, inferior rim is involved first, followed by the superior rim. Now, that's not always the rule, but in almost 90% cases, the inferior rim is the first to be affected. So, you will have a focal rim thinning in the form of a notching. So, if this is not controlled well with medications, it goes on to become a diffuse rim thinning. Now, you see there is a thinning of the temporal as well as the superior as well as the inferior neuroretinal rim parts. So, there is a diffuse neuroretinal rim thinning, and because of this thinning, the size of the cup has increased much more than at presentation. Sometimes the thinning is progressing, but there is also an excavation of the neuroretinal rim. And so the blood vessel that was going over has now suddenly dipped, and you cannot see the blood vessel here. If you remember, during the war movies that we are shown in 1857 or other war movies in India, there used to be a bayonet in front of the rifles, in front of the guns. So this bayonet, this part suddenly disappears. So this is the bayoneting sign. The sudden disappearance of the vessel because of the excavation of the neuroretinal rim, that is the bayonetic sign. And because of loss of the nerve fiber on the neuroretinal rim, you will have a nerve fiber layer defect in the rest of the area surrounding the optic disc, and you can see it in the red free light. So here is a disc. We have attenuation of the arterioles. This blood vessel, which was earlier supported by the neuroretinal rim, is now bare because there is no neuroretinal rim under it, and that is called as bearing of circumlinear blood vessel. And if you look at these blood vessels and look at the bend, how they are disappearing, this is the bayoneting sign. And because the nasal rim has become so thin, the vessels which were centrally located have now fallen towards the nasal neuroretinal rim, and this is called as nasalization of blood vessels. So bayoneting, nasalization, bearing of circumlinear vessels are optic nerve head signs. On the contrary, Roenne's nasal step or just nasal step is a visual field sign. So at the beginning, we have development of a nasal step. Some patients can have a temporal wedge formation. Once the disease progresses, this nasal step can progress to a superior arcuate defect. Now, this is an incomplete superior arcuate defect. Once you have more defect coming up inferiorly, this becomes a biarcuate defect. As long as the arcuates are not touching each other, it is an incomplete biarcuate defect. But the moment you have a visual field defect which is connecting with each other, both in superior and inferior hemispheres, it's called as the complete biarcuate defect. Some patients can have just a superior fixation threatening the paracentral area. So, if it is closer to the macula, it's going to disturb the patient more because of drop in vision. And these are the other formats. But remember, the patient gets a tunnel vision in the end. So the macula usually, or the center usually, is spared till the end. Till the end, the patient can have 6/6 vision with 0.9 cup disc ratio. So vision per se is not a criteria to tell whether this patient has advanced glaucoma or not. So rest of the signs that were given in the options were optic disc signs. It was only the Roenne's nasal step, which was a visual field sign and therefore was a misfit in that group. Going on to the next question. We are given certain options and we are told about the parameters and the correct tests to match them with. We are given color vision, intraocular pressure, peripheral vision and central vision, and the options include perimetry, applanation tonometer, tangent screen test and Ishihara testing. And the corresponding numbers are given as options. So color vision is checked by pseudo-isochromatic Ishihara plates or Ishihara chart, and here we see how the color vision can be checked using this chart. This is one of the slides with the plates. The intraocular pressure is checked by Goldman applanation tonometer. As you can see, using the cobalt blue light, there are two semicircles that are formed, and the end point is that the inner margin of the lower semicircle should touch with the inner margin of the upper semicircle. Peripheral vision can be tested using a perimetry machine. So here we have a Humphreys visual field analyzer, which is a static automated perimetry machine. The central vision was checked using tangent screen test, which is the option given here. Nowadays, central vision can also be checked using the perimetry machine. But if the answer is tangent screen in the options, then it is used for checking central vision. So based upon that, you can mix and match and find out the correct option. Then there was a question about which drug acted by increasing trabecular meshwork outflow. So the options were timolol, netarsudil, brimonidine and acetazolamide. Netarsudil is a new addition in the armamentarium for glaucoma medications. Although we all know ABC, that is alpha agonists, beta blockers and carbonic anhydrase inhibitors. ABC helps in decreasing the production of the aqueous. So basically, glaucoma is nothing but a plumbing problem. You have to adjust the faucet and open the drain. Aqueous humor production needs to be reduced. So ABC come in handy there, and the trabecular outflow and the uveoscleral outflow need to be increased. And so prostaglandins and the newer netarsudil, which is basically a ROCK inhibitor, that comes in handy in increasing the outflow. So this is a diagram which shows which drug is acting where. Alpha agonists are causing vasoconstriction and reducing the production of aqueous humor. Carbonic anhydrase inhibitors, as the word is telling, is inhibiting carbonic anhydrase at the level of pigmented epithelium of the ciliary body and reducing the production. Beta blockers and alpha agonists are acting at the site where sodium-potassium ATPase is occurring, and they are inhibiting it and therefore reducing the production. Prostaglandin analogs are widening the trabecular meshwork and increasing the outflow. The alpha-2 agonists also relax episcleral veins and contribute a little bit towards the outflow as well. So if you are asked an option wherein which drug has a dual mode of action, it reduces production as well as increases outflow, the answer would be an alpha agonist and brimonidine. If you are asked about a drug which improves the optic nerve head blood flow, the answer would be a carbonic anhydrase inhibitor, dorzolamide. If you are asked about which drug reduces the blood supply to the optic nerve or causes vasoconstriction, then the answer would be brimonidine. The newer ROCK inhibitor or netarsudil also acts by increasing the outflow, as is evident in this diagram. So the correct option would be Netarsudil, because the rest of the drugs that were given in the options were reducing the aqueous production. Going on to the next question, what is the drug used in a patient with increased intraocular pressure and optic disc changes with ciliary congestion for decreasing the IOP that acts by increasing the outflow? So basically, outflow is increasing and we are giving it in a patient who has ciliary congestion. So any pro-inflammatory drug is usually avoided when already there is congestion. So pilocarpine is considered to be one of the most pro-inflammatory drugs. And if there is congestion, there is severe amount of intraocular pressure elevation, it's less likely that pilocarpine alone is going to work. The other options that we have are Latanoprost, which is a prostaglandin analog, dorzolamide, which is a carbonic anhydrase inhibitor, and timolol, which is a beta blocker. So again, revisiting what is acting where and doing what. So adenosine alpha AI agonist, trebodenosone, which is a newer drug in the making, Ropesa or Roclaten, which inhibit the Rho kinase. These are acting on the trabecular meshwork and increasing the outflow. Now, pilocarpine has been considered to be a good outflow increasing drug, more so in angle closure, but it also works in open angle glaucoma if there is no inflammation. Uveoscleral outflow actually accounts for 20 to 30% of outflow, and prostaglandins like latanoprost or brimonidine, as I talked about in the previous question, increase the uveoscleral outflow. And we know that beta blockers, alpha-2 agonists and carbonic anhydrase inhibitors along with ROCK inhibitors, they also improve upon the reduction in intraocular pressure by reducing the aqueous humor production. So the answer for our question is latanoprost. Now prostaglandin inhibitors are also pro-inflammatory, but per se in an eye which is quieter on the inside, in which there is lesser or no uveal inflammation, prostaglandins have now been considered to be a safe option. Prostaglandins are avoided in patients who have macular edema or who have an active herpetic infection or any other viral infection, because they can lead to reactivation of a dormant virus if there is some amount of subclinical activity. Other than that, prostaglandins are now safely given in most forms of glaucoma. So with all the options that we had, latanoprost is the correct answer. It works on ciliary muscles. It causes receptor activation, and by virtue of its action on MMPs and TNF alpha, it increases the aqueous outflow, ultimately resulting in lowering of pressure. Going on to the next question, drug of choice in acute congestive glaucoma. Is it atropine? Is it acetazolamide, which is an oral carbonic anhydrase inhibitor? Is it pilocarpine? Or is it a combination of pilocarpine with acetazolamide? Now, acute congestive glaucoma is no longer a word that is used. We talk about acute angle closure glaucoma. In acute angle closure glaucoma, the pressure is usually over 40 or 50. The patient has severe pain in the eye. There is redness, there is watering. The patient can see colored halos. The cornea is edematous and the angles are blocked. So basically what we want to do is open up the angle. Now, if we give atropine in such a condition, atropine is going to dilate the pupil and block the angle further with the iris that is going, and because of the dilatation, and it is going to make matters worse. Giving pilocarpine straight away will not work, because ultimately pilocarpine needs to be absorbed in the iris blood vessels, and then only it can make an effect in causing meiosis and reducing intraocular pressure. Acetazolamide needs to be given for faster lowering of pressure, and in cases where the pressure is much higher beyond 50 or 60, mannitol can also be given and should be given. So here we need to reduce the pressure fast by giving acetazolamide and constrict the pupil so that the eye can be undertaken for a laser iridotomy. So we need pilocarpine as well. So we need a combination of acetazolamide and pilocarpine. Therefore, option D, which means B and C, is the correct answer. So here we know that initial management would require reduction of the high pressure so that the patient is comfortable, the cornea becomes clear. Once the cornea is clear, the pupil is myosed, a hole is made in the iris so that there is a route for the aqueous to flow through. So laser iridotomy is the definitive treatment, and one must also do gonioscopy of the fellow eye also so that you don't miss out on subclinical angle closure in the fellow eye. If there is presence of closed angles in the other eye, laser iridotomy prophylactically must be done in the other eye as well. Moving on to the next question. We have a patient with a history of asthma who reported for primary open angle glaucoma treatment. What would be the drug of choice? Latanoprost, blepharospasm, gemiprost or carbaprost? Gemiprost and carbaprost have been used for causing surgical abortion. Gemiprost is a PGE1 analog and an anti-progestogen. Carbaprost is also a synthetic prostaglandin and binds to PGE2 receptors. It has been shown that the maximum risk for asthma exacerbation following the use of PGE1 is less than 2%. Now, blepharospasm is a prostamide, but the leaflet that comes inside the blepharospasm bottle talks about respiratory adverse effects. The common ones are upper respiratory tract infections. The frequency for asthma exacerbation, COPD exacerbation and dyspnea has not been reported, but post-marketing reports talk about asthma-like symptoms. So all these three drugs in one way or the other may influence asthma of the patient. So the safer option that is left for us out of the option that was given is Latanoprost, and that is the answer for this question. Going on to the next. Which anti-glaucoma drug causes ocular hypotension with apnea in infant? Now remember, brimonidine need not be given in infant or children. So less than 8 years of age of child and less than 20 kg weight of the child, brimonidine or an alpha-2 agonist is a complete no-no because it crosses the blood-brain barrier. It can cause apnea. The child can land up in coma, and it can also result in cyanosis. So the options that we were given were latanoprost, timolol, brimonidine and dorzolamide. So the correct answer is brimonidine. Dorzolamide is a very safe option for infants. Dorzolamide and timolol or a combination drug can be given to a child before we fix the date for the surgery. Now remember, in children, drugs are just a temporalizing measure. The ultimate solution to addressing the congenital glaucoma is a surgical approach. Latanoprost, although not very preferred in children, is still safe and can be given, but brimonidine an absolute no-no because it crosses the blood-brain barrier and results in respiratory depression, hypotension as well as hypothermia. In adults, we avoid brimonidine in factory workers or long-distance drivers because the frequency of instillation of brimonidine is thrice a day and it can cause somnolence, so it can increase the risk of accidents in these individuals. So avoid in factory workers as well as long-distance drivers to avoid accidents. The next question talks about atropine. Where is atropine contraindicated? Is it contraindicated in acute congestive glaucoma and acute anterior uveitis, malignant glaucoma or corneal ulcer? We have already talked about this question in a different format in the previous slides. For acute congestive glaucoma, we need to give pilocarpine. So definitely atropine is contraindicated here. Atropine is a must for corneal ulcer and acute anterior uveitis. Malignant glaucoma occurs usually after surgeries, after a trabeculectomy or after a cataract surgery. So here atropine helps to reduce the ciliary spasm and it is helpful rather than contraindicatory. So for these three, atropine is a must, and the odd one out here is the acute congestive glaucoma. Another new use of low dose atropine that has come up recently is for slowing down the pace of progression of myopia. So low dose atropine is given in myopes. These are the other indications. The ocular side effects also need to be remembered. When we are giving atropine to a child, it's important that we tell the parents that the child can have mild fever after installation of this drop. There can be contact dermatitis on the lid skin. So if you are giving and if there is a slight redness, it is better to put a coat of Vaseline or coconut oil on the skin before installation of atropine. And if the irritation or the dermatitis is severe, stop the drug. So the correct answer is acute congestive glaucoma. Moving on to the next. Which of the following is a direct gonioscope? The options that were given to us were Coleman's, Koppe's lens, Zeiss lens, or a Richardson lens. So a combination had to be made and the correct answer would be given accordingly. So basically, direct gonioscopy means that you are visualizing the angle directly. But this we do only in children when we are in the OR, and using a transillumination source, we look at the angle. For this, we need to tilt the head of the child, we need to tilt the microscope so that we can directly view the angle. An easier way is to use indirect gonioscope in the OPD settings, wherein you can visualize the light. Now, the light bends at the interface of cornea and ear, and it hits the mirror on the gonioscope, and what we visualize is actually a reflection which is coming from the mirror of the gonio lens. So what we are seeing is an actually opposite angle when we are viewing or visualizing. Dynamic compression is done in cases of angle closure. So with this indirect gonioscope, if you press upon the cornea, then there is a displacement of aqueous which can open up subacute angle closure patients. So if the patient has a mild elevation of pressure and Van Herrick's 2 type of an angle closure, and if you press with the gonioscope, the fluid gets displaced and it opens up the angle. This is called as dynamic compression or dynamic gonioscopy. So for direct gonioscopy, the different lenses that are available are Koppe's lens, Hoskin-Barkan lens, Wurst lens, Swan-Jacob lens, or Richardson-Schaefer lenses. So amongst them, a very characteristic thing about Richardson-Schaefer lenses is the small size, and therefore it is very suitable for infants. Others are a little bigger in size as compared to this lens. Direct gonioscopy allows the chamber angle light rays to be refracted directly through the cornea contact lens interface. So here you see a Hoskin-Barker lens, and this is a Koppe's lens. A handheld gonioscope is required for magnification and illumination, so it's not really very comfortable using the older lenses like the Hoskin-Barker or the Koppe's lens, because you need to use both your hands and tilt the microscope to visualize the angle. The newer lens, direct gonioscopy lenses that are preferred include the Swan-Jacob lens. So the answer is Koppe's and Richardson's, and that befits the option B. So you need to know the names of all the direct gonio lenses that are used in clinical practice. The next question is a true statement. Which of the following is true about glaucoma? The early and specific feature is isopter contraction and there is bearing of blind spot. In static perimeter, the intensity of stimulus is kept constant while it is moved. Visual field defect to be associated with glaucoma only if it is associated with optic nerve head changes. Kinetic perimeter is best for monitoring visual field changes in a glaucoma patient. Now we need to understand the difference between static and kinetic perimetry. So imagine Harry Potter on its broomstick. Now Harry Potter on the broomstick is going around this island and drawing the isopters. This is kinetic perimetry. On the other hand, we have a rock climber who's climbing this island and looking at various points on this hill of vision. So this rock climbing guy is just like static perimetry, and the hovering Harry Potter is the kinetic perimetry. The isopter contraction does not give us as much information when it comes to depth of glaucoma or the change in the defects on the visual field over a period of time. So that answer we get by the static perimetry. So for us, static perimetry gives us more answers in terms of depth, in terms of changes and progression in glaucoma. Bearing of the blind spot is not the first sign in all patients. It is very variable. Some patients may have a nasal step, some patients may have a bearing of nasal spot. So we cannot use a blanket statement that bearing of the blind spot is the first thing to go. However, visual field defects need to corroborate with the optic disc changes and the characteristic visual field defects in the form of a visual field defect along the horizontal meridian, which matches with the neuroretinal rim of that patient, would give us the correct answer, and that is the correct choice. Now, some patients, for example, may have multiple diseases. So, a glaucoma patient can have diabetes, and for their diabetic retinopathy also, they would have undergone a pan-retinal photocoagulation laser. So, the laser marks would also be there on the retina, and they would also produce a corresponding defect on the visual field. So, whenever one is analyzing a visual field, the visual field defect should correlate with the fundus pathology, irrespective of whether it is glaucoma, whether it is a chorioretinitis patch, whether it is a laser mark. It has to match correspondingly. Otherwise, you need to sit with your patient and explain to them what to do and how to do a visual field test. So, the correct answer out of the given options would be visual field defect corresponding to the optic disc image. Now, in this entire hill of vision, the sensitivity of different points is different. Central 5 degree, the sensitivity is somewhere between low to mid 30s, and as we go out, the sensitivity reduces. So, from 5 to 30 degrees, the sensitivity is somewhere between mid to upper 20 decibels, and beyond 30 degrees, it is in the late teens to early 20 decibels. So, in the center, we have the maximum sensitivity, and as we go downhill, the sensitivity drops down. Younger individuals have more retinal sensitivity as compared to the older individuals. The answer we have already talked about. Moving on to the next. Which of the following triad is seen in angle closure glaucoma? So it's important to know all these triads. Vogt's, Virchow's, Hutchinson's or Goucher's triad. Let's have a look at each of them. Vogt's triad means glaucum flecken, which is nothing but anterior subcapsular lenticular opacities, patches of iris atrophy, or slightly dilated non-reactant pupil. And in our case, we have a mid-dilated pupil due to sphincter atrophy. So this is Vogt's triad, which is seen in angle closure glaucoma. Virchow's triad is seen in central retinal vein occlusion, and it includes vessel damage, stasis, as well as hypercoagulability. On the other hand, Hutchinson's triad is seen in congenital syphilis. There are teeth malformations, there are Hutchinson incisors and Mulberry molars, there is sensory neural deafness and interstitial keratitis. So these three monkeys will help you remember the Hutchinson's triad. Teeth, ear deafness and keratitis in the eye. There is also a sculptured nose and saber shins seen in congenital syphilis. Goucher's triad includes rigidity of the neck and the trunk. There are bulbar signs, particularly there is a severe swallowing disorder and there is oculomotor paralysis, and the patient can have bilateral fixed strabismus. So Goucher's triad is seen in Goucher's disease. So our options befitted well in angle closure. So Vogt's triad pertaining to acute angle closure glaucoma. Glaucum flecken, irisotrophic changes, as well as a mid-dilated pupil. The next question asks about which of the following procedure involves a glaucoma drainage device? A Seton operation, deep sclerectomy, viscocanalostomy or trabeculectomy. Trabeculectomy, if you know, is a glaucoma filtering surgery procedure. Basically, what we are doing is we are creating a flap, then we are entering and removing a block of trabecular meshwork, doing a broad-based iridectomy and actually creating a conduit Photoaqueous to flow from inside the eye, underneath the flap and underneath the conjunctiva. And this results in formation of a bleb in the area of conjunctiva. You can have a fornix-based flap, you can have a limbus-based flap, and ultimately you will get a filtering surgery and formation of a bleb. Deep sclerectomy and viscocanalostomy are called as non-penetrating glaucoma surgery or NPGS. They don't create a bleb, but they create an outflow pathway where there is no problem related to bleb-related dysesthesias. So basically, we are creating two flaps in this. We raise one scleral flap and then we cut another scleral flap. That's why, since we are cutting a deep scleral flap, it's called as deep sclerectomy. Opening up the Schlemm's canal after doing deep sclerectomy by putting viscoelastic material in the Schlemm's canal is called as viscocanalostomy. Another NPGS, non-penetrating glaucoma surgery. These are various implants, the glaucoma drainage implants that are available to us. We have the Paul implant, which is recent, an glaucoma valve, a clear path, the iWatch system, the Molteno implant, and the Barwelt implant. Now, all of these implants have a body and they have a tube. Some of them may have a valvular mechanism, others don't. So, this tube is actually like a ceton. Now, ceton is nothing but a thread or a conduit which facilitates drainage. It has been used in several other surgeries like perianal fistula drainage. For glaucoma, that concept was applied to form a drainage implant. So, ceton operation is nothing but a glaucoma drainage implant procedure. For your knowledge, just I'm showing different type of implants. Valved is AGV. You can have a single plate or a double plate, and these are the name of the models. For a single plate, remember the diameter is 184. It doubles up for a double plate. A pediatric valve size is much smaller. It's about 96. The valve material for adults is polypropylene. We also have silicone for children. So, pediatric is silicone and for adults is polypropylene. Non-valve implants include the Barwelt implant, the clear path implant, and the Molteno implant. And the answer for our question is a ceton operation. So, here you have the body, the tube or the ceton is going in the anterior chamber, and to prevent tube erosion, there is a scleral patch graft that has been fixed to the eye. Ceton operation is synonymous with a glaucoma drainage device or a glaucoma drainage implant. The next question looks at a 77-year-old woman who presented with deteriorating vision in the left eye for several years. On examination, the eye is red and painful. The intraocular pressure is very high. It's 60 millimeters in the left eye and 18 millimeters in the right eye. There is left corneal edema. The anterior chambers are deep, particularly on the left side. There is flare and cells on the left and a white lens. What is the most likely diagnosis? Now, pressures are very high, so the left eye seems to be involved. Flare and cells are there. That means there is some sort of an inflammation that is going on. The anterior chambers are deep. That means that we are rolling out acute angle closure. And there is a lens which is there. There is a white lens. So, the options that we have to consider are Fuchs heterochromic uveitis, phacolytic glaucoma, phacomorphic or intumescent glaucoma, or Posner-Schlossman uveitis. Now, let's look at different forms of inflammations secondary to a lenticular pathology. The phacomorphic means that the lens is swollen. It is so swollen that it is pushing the iris towards the angle. So, that will result in secondary angle closure glaucoma, which will cause the pupillary block and resulting in elevation of pressure. Now, our patient had deep ACs, so this does not seem to be the correct choice. Let's go to phacolytic. In this, there is a mature cataract which leaks out its denatured lens proteins, macrophages, phagocytes, and these proteins, they are swimming in the anterior chamber and they ultimately go and clog the trabecular meshwork, resulting in a secondary open angle glaucoma. This could be a possibility in our patient because the patient had a cataract, patient had a lot of cells and flare which could be coming up from the leak proteins. Then we have another entity which is called as a phacoantigenic glaucoma. Here, normal lens proteins leak into the anterior chamber, and this is usually seen after trauma or capsule disruption. A granulomatous reaction to these normal proteins also ensues. Lens particle glaucoma means pieces of lens particle which were left after you have done a cataract surgery physically obstruct the angle. So the lens is gone. We have an artificial lens here, but there are some leftover chunks of the cataractous lens which are blocking the angle. So this is also not an option. This is not also an option. We are considering these two. Patient did not have any trauma. So phacoantigenic also seems unlikely. So the option most likely seems to be phacolytic glaucoma. This is a quick peek into the triggering factors and the offending agents that result in elevation of pressure in patients with lens-induced glaucomas. So for phacolytic glaucoma, the offending factor is macrophages and lens proteins and inflammatory cells. For lens particle glaucoma also, they are the same. Next, exfoliative glaucoma, we have the fibrillary proteins and gags as we talked about earlier. So the correct answer is phacolytic glaucoma. Some other miscellaneous inputs that I would like to share with you. You can be asked a question about causes of trabecular pigmentation. Remember the mnemonic pigment, which stands for pseudoexfoliation and pigment dispersion syndrome. G stands for glaucoma, which is the post-angle closure glaucoma. Sometimes patients with angle closure can have patchy pigmentation on the anterior trabecular meshwork. ME stands for melanosis of the angle, which is seen in oculodermal melanosis. N stands for nevus, which is seen in Cogan-Rees syndrome, and T for trauma. So pigment mnemonic can help you remember the causes of trabecular pigmentation. A few more MCQs which have not been asked in the previous exams, but that's just to cover a few additional concepts related to glaucoma. Open angle glaucoma causes sudden loss of vision. I don't think so. Difficulty in dark adaptation, amaurosis fogis, or uniocular diplopia. Now, we are not dealing with muscles, so this is definitely not an option. Sudden loss of vision does not happen in open angle glaucoma, but in a patient with acute angle closure glaucoma with very high pressures and corneal edema, they can have a drop in vision. So this would pertain to an ACG, not an OAG. Amaurosis fogis means sudden loss of vision for a few seconds and then the vision comes back. So this is usually seen in retinal vascular disorders, but not in open angle glaucoma. Now, difficulty in dark adaptation is a complaint that most glaucoma patients have as the disease progresses. Now, there is poor contrast sensitivity in these patients, and these patients take a long time to adjust to light whenever they are going from brighter place into a relatively darker place. So, difficulty in dark adaptation is the correct answer. You can be asked about which cells affect the glaucomatous optic neuropathy. Are we dealing with amacrine cells, bipolar cells, ganglion cells, or rods and cones? Now, we know that there is retinal ganglion cell damage that is happening over a period of time because of the apoptotic changes, and we are measuring the retinal nerve fiber layer as well as the macular ganglion cell layer by OCT to check for disease progression and look at the retinal nerve fiber layer thickness. So, the correct answer is ganglion cells. Goldmann tonometer is a type of applanation tonometer, rebound tonometer, indentation tonometer, or a non-contact tonometer. A non-contact tonometer uses an air puff. An indentation tonometer is, as the name is suggesting, is indenting on the cornea, and the example for that is a Schiortz tonometer. A rebound tonometer, the example for which is the eye care tonometer, is using a different concept altogether to measure the pressure. Goldmann applanation tonometer is applanating a 3.14 millimeter square area of the cornea, and it is based on the modified Imbert-Fix law, and it gives us the precise value of intraocular pressure. Goldmann applanation tonometer is considered as the gold standard for tonometry. Which of the following procedures is not done in dilated pupil? Now we want to look at the angle. We want the iris to be away from the angle. So we can look at the pigmentation and the different structures that are there in the anterior chamber angle. So we don't want it to be dilated. So for gonioscopy, we don't need a dilated pupil. So this is a 3-mirror lens that we are seeing in this image, and we are trying to do gonioscopy using this. So if you see that the angle is not dilated and all structures in the angle can be visualized. For fundoscopy, to see all the details of the retina, the disc, the macula and the periphery, we need to dilate the pupil. For ERG and laser interferometry also, we get a better response if the pupil is dilated. So with this, we come to the end of glaucoma subsection. I would request you again to go through the slides once again so that everything is consolidated. And with this consolidated knowledge, you perform your best. All the best.